All right, thanks again, Marla. Safe travels. Moving from birth to the other end of the spectrum, here we're going to talk about treatment of IBD in older individuals. What I want to cover over the next 20 minutes is to look at the burden of IBD in older people and understand why this is really an important problem that we need to be paying attention to. Talk about the phenotype and natural history of IBD in this population, see how it differs from the IBD in teens and 20s that we think of. Look specifically at the safety of medications in older patients. I think this is a very important question that we all struggle with. Let's see what data there is to give us comfort or not. And finally, specific principles that may hold in the management of IBD in older patients. So the reason this is such an important topic, and we are increasingly talking about it more so than even 5 or 10 years ago, is that with the aging of population in general, the proportion of our IBD patients who are going to be older than age 60, 65 is only going to grow. So this was a modeling exercise we did when we published it a couple of years ago, looking at how IBD is going to look in somebody's practice in 2015, which is the very bar that's closest to me, to 2060, which is all the way there. And we divided sort of the population into 3 groups, 0 to 64, the light orange, 65 to 84, which is the dark orange, and then the light blue, which is those older than age 85. And essentially, rather than look at the numbers, I just want you to look at the proportion of these bars that are occupied by the dark orange and blue. And you see that's moving from 2015, where there's a sizable number, but still a small subgroup, to 2060, where this orange and blue bar, which is over the age of 65, is really going to be almost half our IBD population. Fortunately, with all of our effective treatments, people aren't dying of IBD anymore, but as people are growing older, that means they're just going to have IBD for longer periods of time. Other studies have also shown that about 15% of new diagnosis of IBD that happens after the age of 60 years. So not only are people going to have had IBD that they developed in their 20s and 30s and are now aging, but they're also going to be a good number of patients who develop IBD for the first time, even beyond the age of 80 or 85 years. Is IBD different in older patients? We have some very good data, including this study from Northern France that looked at the phenotype of IBD in older patients over the age of 65 years compared to those who had this disease earlier. Essentially, what you see that in Crohn's disease, there's more frequent colonic involvement. So L2 phenotype, which is what we think of as isolated colonic disease, which is the light green bar here, is far more common in those over the age of 60 years compared to those who are diagnosed below this age, where small bowel involvement is far more common. In ulcerative colitis, you see less frequent isolated proctitis in patients who are diagnosed over the age of 60 years. And in fact, the most common phenotype in this group is going to be left-sided colitis, as opposed to those who are diagnosed at a younger age. Complicated Crohn's disease at diagnosis, or progression to complicated Crohn's disease of stricturing or penetrating phenotype, is also less common in older onset patients. You see here over the age of 60 years, primarily if they have Crohn's disease, they're going to have B1 phenotype as well, which sort of correlates with having isolated colonic disease more commonly. And this is just sort of indicating over time from diagnosis to 15 years that there's a larger proportion who are going to remain as inflammatory non-penetrating stricturing when they're diagnosed older. But that being said, those data points sort of give us false impression that disease is actually less severe in older patients. And as a consequence, that's reflected in our practice, and that's not necessarily the case, as you'll see here in the next few slides. So this was a study done from the University of Pittsburgh that they published about 5 years ago, just taking cross-sectionally all their patients with IBD who are older than age 60 years. And they created this very nice pie chart that breaks down the different treatments that these patients are on. And you see here that 32% of their patients who are over the age of 60 years were being maintained on systemic steroids for their maintenance because of 2 factors. One, perceived lower severity, so we don't think they're going to develop complications, so we're withholding potentially more effective drugs that we are scared about. And also, we are not aware as much about the safety of the newer medications in older patients, but we're familiar with the use of prednisone, so we sort of rely on that as the stopgap therapy in older patients. And you see here 30% were on prednisone. 44% were on 5-ASA therapies, which we know are generally ineffective in Crohn's disease. Granted, this pie chart includes both with Crohn's and ulcerative colitis, but a sizable proportion of older patients with Crohn's disease were being maintained on either prednisone or 5-ASA therapy, and very few were on therapies that we now consider more effective, either 6-MP, azathioprine, or biologic therapy. And this is by no means unique to the University of Pittsburgh. If you take any of our patient population and look at what we're doing to patients over the age of 60 years, you'll see pie charts that are not remarkably different from this. This was a Spanish study that looked at almost 1,400 older onset IBD patients, a very, very large sample size, of whom about 2/3 had ulcerative colitis, the rest had Crohn's disease, and compared it to younger onset controls. And there are some important takeaways from this graph. So you see that corticosteroids in this cohort were being used similarly as in younger patients, but your immunomodulator and anti-TNF therapies were being used far less common. So if you look at either disease, either ulcerative colitis or Crohn's disease, and look at older patients, which are the dark gray bars, and the younger patients, which are the light gray bars, much less use of immunosuppressants and anti-TNF, whereas two important things. The rates of steroids were similar, the rates of surgery were similar. So this sort of, I think, highlights the false perception again that disease is less severe in older onset IBD, and this tells us that's not really the case. These patients are getting operated on at the same rate as a younger patient. They don't have less severe disease. We're just using our more effective therapies less often in these patients, in part because we're just not as familiar about the safety of these medications in this population. That very same point was confirmed by this Japanese study, again, very, very large numbers. So almost 3,000 patients with elderly onset ulcerative colitis compared to 25,000 younger onset ulcerative colitis patients, right? And older onset disease, depending on your endpoint, was actually more severe. So older onset disease resulted in more frequent hospitalization. Nearly 50% of older onset UC patients were hospitalized compared to only 1/3 of those who were diagnosed below the age of 60. Surgery was far more frequent in older patients, again 0.7% versus 0.3% in this cohort, and much greater use of steroids in this Japanese population, 37% versus 31%. So absolutely the first take-home point from this first part of the talk is that patients who develop ulcerative colitis or Crohn's disease at an older age are not going to have milder disease. They have slightly different phenotype. Maybe the rate to penetrating and stricturing disease is less, but the impact of disease as measured by need for steroids, need for surgery, need for hospitalization is similar or higher in this patient population. And so we should be thinking of more effectively getting the disease under control in this group. The reason we're relying on corticosteroids is that there's not a lot of data on safety of the other individual medications in older patients. It's important, as in younger patients, to recognize that steroids are not maintenance medications in older patients. They can be used for induction of remission, but are not necessarily good for maintenance of remission in older patients as they are in younger patients. And older age results in several steroid-related complications being more common. Studies have highlighted the increased mortality and risk of serious infections in older patients in general, but certainly with steroid exposure. I've listed here in a box all the steroid-related side effects that happen, and many of them can really have a significant impact on older patients, particularly mood, lack of sleep, falls, skin thinning, hyperglycemia. There are a number of side effects that older patients, you can imagine, are more vulnerable to when we talk about steroid-related side effects. Steroids with a high first-pass metabolism, like budesonide, there's no long-term efficacy or safety data in general for these medications in Crohn's disease or ulcerative colitis as maintenance agents. However, there is data from microscopic colitis studies that some of these medications can be used longer for that indication. They may have a role in persistent symptomatic mild Crohn's or in ulcerative colitis patients who have a 5-ASA hypersensitivity. But again, we shouldn't be relying on them exclusively as maintenance agents in older patients. We wouldn't be relying on them in younger patients as well. There are some practical points with these medications that they're not always covered by Medicare. And adverse events can occur in 1 to 10% of patients, steroid-related adverse events, particularly with prolonged use. So we should still consider a steroid-sparing strategy when we're initiating these medications. But in comparison to prednisone, this may be the safer steroid option that we should use in older patients. In terms of thiopurines, again going back to the Spanish study that looked at both thiopurines and anti-TNF in older onset IBD patients, what they showed was that older patients in general who were prescribed thiopurines had more hepatotoxicity than younger patients who went on thiopurines, but were less likely to have pancreatitis. On the other hand, anti-TNF patients had more infections, but fewer infusion reactions. So overall, while the pattern of adverse events seem to be similar in older patients and younger patients, there may be subtle variations in which side effects are more common in older patients and which side effects are less common. And you see here what I was talking about there. This was an Italian study that included about 100 patients who were over the age of 65 when they initiated either infliximab or adalimumab and compared their outcomes to matched group of younger patients who started the same treatment and also to older patients who are not treated with anti-TNF therapy. And the take home from this slide, I don't expect you to read any of those individual boxes, but there were significantly higher rates of severe infections and mortality in older patients compared to younger patients. So the top box is those over the age of 65 treated with biologics, and the bottom two groups are over the age of 65 treated with other drugs and less than 65 years. And all you need to take away is look at the size of the boxes, and clearly the top group has more adverse events happening in terms of infections. But important things to keep in mind. So this was a study that we did that we published about 5 years ago comparing older patients who are starting biologics to younger patients, and also showed something similar. If you look at time to cessation of biologic therapy, it was more common in older patients than in younger patients. That being said, this is in large part a reflection of age and not a reflection of biologic therapy. When we've done other studies where we've compared older patients who are on an anti-TNF compared to those who are on placebo, for example, clinical trials, there is no incremental safety concern in older patients. So while the baseline rate of these infections go up in older patients, that's why we're seeing a difference in older biologic users compared to younger biologic users. But you see very similar differences in older patients treated with placebo in clinical trials as younger patients. So this is a reflection of those side effects being more common with age, and not necessarily that these medications are more dangerous in older patients. It's just your entire baseline shifts, and so that's why you see these differences when you compare older and younger patients. And so this was something, again, similar, that a common reason for therapy cessation in older patients is infections, and that's something we need to be aware of. The role of combination therapy in older patients is less certain. There's far less data. In a single center study, combination therapy in older patients was associated with a twofold increase in risk of therapy cessation, primarily from infections. However, an analysis of the REACT trial, which was a trial that looked at combination therapy initiated early after therapy, or early after diagnosis in Crohn's disease, showed that there was really no increase in serious complications in older patients on combination therapy, and in this case it was adalimumab either with thiopurine or methotrexate. Pooled analysis in general of other trials that have looked at these therapies across all age groups have shown that there is an increased risk of infections, lymphoma, and non-melanoma skin cancer that happens with combination therapy compared to monotherapy. So my take home is that our default position in someone who's older should not be combination therapy, but when the right scenario arises, that we can use it with caution on a case-by-case basis. So we would use it a little bit more prudently than we would in a younger patient. What about other biologics? Are gut-selective biologics any safer? So this was a study that we published earlier this year looking at the experience of 3 high-volume IBD centers, looking at patients who initiated either Vedolizumab or Anti-TNF when they were over the age of 60 years. And essentially we saw that there was no difference in infections, no difference in other outcomes between patients who initiated either Veda or anti-TNF, suggesting that perhaps both are similarly safe in this population. We did see that there was a trend towards a higher rate of remission in Crohn's disease with anti-TNF early on at 3 months, though at 1 year there really wasn't any difference between two groups. So broad take home from this study, both seem similarly safe, maybe a slight difference in speed of onset of action, but overall outcomes are very comparable between one and the other in this population. Again, small numbers. This is a single study and we need larger data, but that's sort of our experience. What about the other newer medications? For psoriasis, there were 24 patients over the age of 65 who were treated with Ustekinumab, and none of them had any serious infections at 1 year. take it for what that's worth. There's no large comparative data. Generally seems to be safe. In rheumatoid arthritis, when patients over the age of 65 were treated with tofacitinib, there was a numerically higher rate of serious infections in older patients compared to younger patients, but as we saw, you're going to see that difference for virtually every medication and for placebo, because older patients are going to have more serious infections in general, independent of therapy. It's important that as people grow older, there's an increased risk for herpes zoster, so keep that in mind when you're putting your older patients on tofacitinib, that there is an age-related increase that changes their baseline. Another specific age-related concern that has come up with tofacitinib that we don't have a clear answer was this black box warning for pulmonary embolism in older patients from a rheumatoid arthritis trial that included those over the age of 50 years who had at least one cardiovascular risk factor. So this is something, again, that we want to keep in mind when we are considering this drug in older patients. Again, how much is drug-related, how much is infection-related or inflammation-related, it's not clear, but keep that in mind when you're making your therapeutic choice. It's also important to remember that we should not forget surgery in older patients, but that these patients don't necessarily bounce back from surgery as well as younger patients. So this was a large study that looked at over 15,000 IBD patients, of whom 11% were elderly, and looked at various complications after surgery, and things definitely are slower to recover when someone has surgery when they're older. It's further important to keep in mind that any delay in surgery further extends this difference between younger and older patients. So if we're thinking about surgery in older patients, we need to be proactive about when to do it, and do it when there's a lot of reserve still left than when they've been ill and dragged on therapy that's ineffective for months and years. The most important age-related complication of therapy is infections. It's important that our risk factors for infections can be separated as disease-related, medication-related, and age-related, and that really very few risk factors are non-modifiable. So we don't just throw up our hands and give up saying older patients are just going to have infections, because age, comorbidity, their IBD type is not modifiable. But if you go back to the previous slide, a lot of these risk factors for infections are modifiable. So use of steroids, use of combination therapy, narcotics, need for TPN, malnutrition, emergent admission, all of these are modifiable risk factors that we should be addressing in our older patients to prevent infections, which is the single most important thing that takes older patients on therapy down. Other things that we should do to prevent infections, as Frank mentioned in his talk, it's really important to vaccinate these patients. A lot of the therapy-related infections are preventable. It's important to not lose sight of this in the midst of trying to treat their IBD and managing all their comorbidities, optimize nutritional and functional status, avoid narcotics, avoid prolonged steroids. We saw in the case discussion of the 68-year-old patient that I presented who'd been on 40 milligrams of prednisone for a month. That's not something that we should be doing in our older patients. We should be getting them on steroid-sparing therapy early, trying to keep older patients out of the hospital. It's really important in sort of just wrapping up this talk to think of the impact of age and comorbidity and how we manage these older patients. There's a higher frequency of depression in older patients. We should be aware of that. Depression is a significant negative impact on quality of life. We have to screen for depression in older patients. We should be screening for depression even in younger patients with IBD, but certainly should be screening for this in older patients and treating it appropriately. That's sometimes the single biggest impact we can have on their quality of life, is identifying depression and other mood disorders. It's important that with age, there may be an increased prevalence of cognitive defects, so we need to keep our treatment regimens in older patients simple. We cannot be having 4 times a day treatment, a couple of suppositories at different times of the day, enemas. Those are therapies that in the midst of all their pills, they're absolutely not going to be able to do. So it's very important to try to keep treatment regimens simple, including tapering off, have everything sort of be very systematic and simple. In terms of contraindications for specific treatments, it's important to recognize that congestive heart failure, when it's decompensated, is a contraindication for anti-TNF therapy, but that is the only cardiac contraindication for anti-TNF therapy. If someone has coronary disease, has had a heart attack 20 years ago, that is not a contraindication for anti-TNF therapy. So it's really decompensated congestive heart failure. It's important to recognize the impact of diabetes. Sometimes we don't pay enough attention to comorbidities. We should realize that diabetes, particularly when it's poorly controlled, is essentially a steroid equivalent. So if someone has a blood sugar of 200 or 300 milligrams, that means that their infection risk is very similar to being on 30 to 40 milligrams of prednisone. And we saw that in the case series as well, where that person had been on high doses of steroid and also had poorly controlled diabetes. So it's very important to keep that in mind and not lose sight of that. Older patients in general have a higher prevalence of sarcopenia, which is a low muscle mass, which means their postoperative complication risk is higher, and that can also result in delayed recovery. Again, it's important to not delay effective needed surgery in these patients because of this reason. The older patients may also have a poor anal sphincter tone, which can result in an increased impact of incontinence in these patients. Some patients, just to get out of the house and be functional, we should think of cautiously using antidiarrheals. Generally, we never talk about antidiarrheals in patients with IBD because we are worried about the complications, including toxic megacolon and just topping up an inflamed colon. But in an older patient who's 80 and has 4 bowel movements a day, but is really worried about incontinence and so is homebound, not able to get out to the grocery store to get their shopping, maybe 1 Imodium tablet a day in the morning can give them that morning where they can still go about their day-to-day activities. So do not underestimate the impact of incontinence and diarrhea on older patients, and really restoring them to their normal functioning as much as possible is the best thing we can do for these patients. And for that same reason, they're not going to tolerate topical therapy. So don't necessarily rely on that in older patients. In terms of cancers, current or prior cancers, if they have significant non-melanoma skin cancer history, avoid thiopurines. If they have had melanoma, avoid TNFs. Generally, those with prior solid organ cancers can be safely initiated on immune suppression, so that's not sort of a lifelong contraindication for going on immune suppression, and certainly you can cautiously reinitiate it in the setting of prior cancers. Take-home messages: we will be increasingly taking care of older patients with IBD. Avoid delay in diagnosis and avoid delay in initiation of effective therapy. What data exists suggests that the risk of infections is incrementally similar in older patients as in younger patients, just that their baseline risk is higher, and prolonged inflammation and malnutrition can further increase that risk, so it's important to get them treated effectively. Maintaining functional independence is really important in older patients. Minimize the impact of symptoms on quality of life, so we sort of shift focus a little bit. In younger patients, full deep remission may be our target. In older patients, minimizing the impact of symptoms is equally important. And it's always important when we're talking about older patients that we're not talking about their chronologic age. There may be a 50-year-old with multiple comorbidities in comparison to an 80-year-old who's really otherwise healthy and who has another 15 years at least to look forward to. So it's not the chronologic age, but the biologic age that we need to keep in mind in determining the treatment algorithm. So I think that's all I have there, and thank you for your attention.